Hey everybody, welcome to another video. This one might be a little bit longer, but it is on emergency airway management and manual ventilation. First, I'm going to go over the equipment. There is a lot of equipment involved in emergency airway management, and the best advice I can give is take the time to get familiar with it. We have an ambu bag. So an ambu bag typically equals 1 liter of air. This is a reservoir, which helps collect oxygen so that we're able to administer 100% oxygen to our patient when we manually ventilate. So manual ventilation is we're essentially breathing for our patient with this equipment. Some have a manometer that you can tell what pressure you're giving. This piece can come off if you need to apply what's called a PEEP valve. And then we have our ambu bag cushion mask. As you can see, one end has a point and the other is rounded. The point goes on the bridge of the patient's nose, and then the bottom part sits right below the chin, right below the lip on the chin. I like to call it the zit line. You will run this on your oxygen flow meter at 15 liters or flush, because we want to be able to give 100% oxygen in order to hyperoxygenate our patient. So I'll put it up just to show you, and then I'll turn back down so you guys can hear me talk. You see that reservoir inflates, so then when you deliver breath, the oxygen reserved in here will enter into the ambu bag to be delivered to your patient. I'm going to turn that off purely for the sake of volume. So when you are manually ventilating your patient, you do what's called the C and E hold. So you'll put the C at the top, your thumb at the top here, your pointer at the bottom, and then these 3 to help hold the jaw. So you'll put it on the nose, and then I'll use the bottom to open up the mouth, and then the 3 fingers to help open up the jaw, and then I pull my patient's head up towards me to help put my patient to that sniffing position in order to open up that airway. After that, you can bag whatever works for you. I've had RTs that hold this up against their body and bag, or like this, whatever is best for you. This is the most typical, and then some people go underneath. You want to have the best tight seal. Sometimes if you have smaller hands, like me, it might take 2 people, one to actually hold the seal and one to provide. And you will watch for chest rise of your patient. So that is manual ventilation. This is a skill that practice. It is your kind of bread and butter of respiratory therapy. Okay. Other airway management this is called an oropharyngeal airway. This helps to move the tongue up and out of the airway and make it easier to manually ventilate your patient. You'll measure this by the corner of the mouth to the jaw to find the best fit for your patient. These come in multiple sizes. After that, you will insert it into your patient going the opposite direction. And then once you reach the back of the throat, you will turn it to help move that tongue up and out of the way so that you can manually ventilate your patient. You can use an oropharyngeal airway for unconscious patients. Conscious patients you do not use an oropharyngeal airway for. So if the patient comes in unconscious, unresponsive, or after you've given medications, it is appropriate to use this. And to take it out, you just pull down along with the anatomy. This is a nasopharyngeal airway. In the NT section video, we talk about these. These also help hold that soft tissue up and out of the way. You can see there's a bevel. This is done by measuring the tip of the nose to the earlobe or the jaw to make sure it fits. Again, I like to use a water-soluble lubricant when I'm inserting these. And you want to make sure the bevel goes medial, into the medial portion. So this goes along with the anatomy. So you'll put the lube on and then insert it into your patient. Except this guy has a weird nose. I would probably end up using a smaller if this was a real patient. So then it sits down into the airway. Sorry. And then if you do need to continually NT suction, you can go down through this airway to suction your patient without causing continuous trauma. And finally, oral endotracheal airways. So what you're going to need is your actual endotracheal tube, appropriate size for your patient. So let me show you a few pieces. This is called the hub, where you will attach your ventilator. Along here we have our numbers. Typically it is best to have these facing to the left, and that's for the best placement into your airway. This is kind of the guide for the best place you want it to sit with your vocal cords, so we shoot for your vocal cords to be between these lines, but we can definitely advance or withdraw depending on our patient. Our cuff, so that we can provide positive airway pressure. Our bevel, and then our what's called the Murphy's eye, and this is so that ventilation can go to both the right and left lung. You'll also notice there is a blue line that is called the radiopaque line. That is so the endotracheal tube can be viewed on the airway. We have our cuff that we can inflate and deflate. And then some facilities have this, some don't. It's called a subglottic evac tube. What it is there is a hole right here above the cuff so that you can suction secretions above the cuff, because that is typically what leads to ventilator-associated pneumonia. So we need our airway, our ambu bag, which we already discussed. This is called a stylet. It is a firm piece of wire that inserts into the airway so that we can have some shape and rigidity to guide our airway in. You just want to be careful not to have the end of the stylet go past the endotracheal tube, so you can bend it to make it work. After that, you can bend it. Some people, and this is intubator's preference, like a little bit of a curve to it. I prefer a curve. I know Heidi prefers hers straight. That's intubator's preference. After that, we need our 10 ml syringe. Before you insert the airway, you make sure that the cuff is holding, and so I'll deflate and inflate just to make sure my cuff has good pressure. After that, I keep that handy because we're going to need that after we intubate to inflate the cuff to provide ventilation. So typically I'll put that, if a patient has a pillow or something, I'll stick it somewhere handy or in my pocket even. Another thing that is pretty common you guys will see is some people just take the 10 ml syringe and apply it straight with air in it so that we can just inflate when it's ready to go and it doesn't get lost. We also need a Tidal Monitor. This one's been open for a while, so it just stays yellow, but these will come out purple. This helps confirm that we are in the airway. So after you intubate, if you manually ventilate and it stays purple, it means you are in the esophagus and ventilating the stomach. If it turns yellow, that means we are getting positive CO2, which is a positive end tidal, meaning we are providing proper ventilation. So yellow, good. Yellow, yes. This is another one I keep handy on me, even if it is an empty intubating. I am in charge of this, and I just keep it in my pocket so I don't lose it. You'll need a cuff monitor, which I will show you guys later. If this happens a little bit later after an emergent intubation, that's just fine. It's part of ICU management. But we're going to show you those. You need a laryngoscope, which is the handle that you intubate with. And then you have a blade. There are two options. There is a Macintosh, which is curved, or a Miller, which is straight. And again, that's intubator's preference. Always with neonates, you will use a Miller due to their airway being mostly cartilage and no rigidity to it. Where adults, you can use this Macintosh. This lifts the epiglottis directly. This sits into what's called the vallecula and lifts the epiglottis indirectly. And again, for adult patients, that is intubator's preference. Because I know Heidi likes Millers, I prefer Macs. They both get the job done. Different ways to skin a cat. Both are appropriate. Before you intubate, you make sure that there is a light on the end of your blade, turns on, so it slides in, and then clicks in, and then turns on. You can see the light. With the light, some troubleshooting is either you tighten the bulb, you replace the batteries in the handle or just get entirely new equipment. If I can tell you guys one thing, it's make sure your backups have backups and that those backups have backups when it comes to emergency airway management. After that, I will show you guys how to twill tie. So get pieces of twill. I like to say get longer than you need because you can always cut off and wish you had more. And then this kind of 1/4 inch, half inch fabric tape that's really sticky. So, and then if you need it, you have saline, and then always make sure you have suction with a yonker available for secretions and aspiration risks. Okay, the laryngoscope always gets held in your left hand. This is a little tip for women like me that don't have strong upper body strength. If you hold lower on the handle and on the blade, you get better leverage, and then keep your elbow in. And then I kind of use like my whole midsection to help me because these sternocleidomastoid muscles are really strong even if your patient is paralyzed. So that's just a few tips for if you're like me and you aren't super strong. So never will you ever be intubating by yourself. You'll always have a buddy, another RT, a doctor. It's a bad day at work if you are ever in a situation you have to intubate by yourself, and it has to be approved by an MD. But, so what you'll do is hold it in your left hand. Per the manufacturer, it has to be in the left hand because that is where the view is. All right. And then you go in on the right side of the mouth and sweep to the left. And my camera friend is going to show you what we are aiming for. So you can get a little lost in here. Let's do that. Oh no, is it not gonna let me switch? You can do that. Hi, sorry guys, you're going for a ride. If you see into the mouth, oh sorry, this is bad videoing. When you get on the mannequins, you guys can look. You're looking for 2 white lines, and I'll look up pictures online for you. 2 white lines, that is your airway with your vocal cords. That is where you are shooting to insert your endotracheal tube. So you'll go in, you make sure your patient is hyperoxygenated, and someone's monitoring vitals. Then you go in, you watch the tube go in between the cords, pull your blade out and close it, pull the stylet, and then you will be able to push it in a little bit more, attach your end-tidal CO2, it goes to the hub. Once you have the tube in, never let it go, inflate the cuff so that you can provide positive pressure ventilation, remove the ambu bag, and then provide ventilation. This is when you will watch for chest rise and color changing on your end-tidal CO2. So a few assessments to make sure you are actually in the airway are mist up the tube, positive end-tidal, chest rise, and bilateral breath sounds. And then you'll be able to provide ventilation. After that, if you are secure, if I know ahead of time I am intubating, I will move my tube so the numbers are to the left. I'll have my vent ready to go so I can just pop them on the ventilator before I secure my tube, but I never let go of my tube. If you ever have an unsecure endotracheal tube, never let go of it. So I'll put my patient on my ventilator. This is a suction Ballard. Once we know we are confirmed in. Next, we will secure our tube with twill tape. So I know I said never to let go, but since he's a mannequin and he doesn't have arms and legs, I think he's not going to get crazy. So you'll get 2 pieces about 2 to 3 inches in length of your fabric tape. And typically I will do this before while we're prepping. So you take sticky on sticky, and put sticky on sticky so that you're making double-sided tape, like that. It is also best practice to put a courtesy tab on one end so that you have a double stick tape. So take the side that doesn't have the courtesy tab, find where you're located. Depending on what facility, some will do it at the lip. Some people say noting where your tube is at the lip is not as good as the teeth due to lips can swell and damage can happen to them. So some will use the teeth. So we're going to say our patient is 21 centimeters at the teeth. And I will go just right above that. And I will begin wrapping my double-sided tape. So then the sticky gets sticky on each other. And then as I bring it around, it will stick to itself and it will be sticky on the outside of the tube. So you guys can see that. Next, I take my twill tape. I'll do it a little uneven. It just helps things. And again, just like with trach care, take your time to make this look nice because take pride in your work. I don't want to see any messy twill tape jobs. So fold it in half, take the kind of bent end, put it underneath your tube. This little loop-de-loop you've made right here. Bring it up and through there. And then just kind of pull, make sure it's nice and secure. Pull your ties. I'll even pull this way. And then I tie a square knot. Or just one knot, whatever your facility or what your practice is. And then I'll position it so that my tube is in a comfortable place for my patient's mouth. And then I will take one end and hold it here on the cheek so it's secure. Bring the other around the patient's head. And I will be honest, these mannequins' noggins are huge. So bring it up above the ear. And so it's secure to your patient. And then take your time to tie this knot so that it's as flat as possible against the skin to prevent breakdown. See, if you guys can't tell, I'm really big on making sure your patients look nice and that there's no breakdown caused by you. This is therapist preference. Some will tie a slip knot. Others will tie a actual knot. I tie a knot because this is my theory. People who tie the slip knots think, oh, when I'm replacing my ties, typically tie replacement is daily or as they get soiled, then I can just take it off. Me, I want it secure so that if something grabs onto that slip knot while they're turning, then my tube won't come loose. And then if I'm replacing my twill tie or adjusting my tube in and out, I'm just going to get clean twill because I'm a little bit of a princess and I like nicer things. So I'm just going to make my patient look nice with clean twill. So that's facility and personal preference. Some people will tie a bow. I like a knot so that it's secure. And then make sure it's flat. Sometimes I'll have my nurse BFF put a finger here so that I can actually get it tight. Depending on what facility you're in, the burn unit, we will put staples above the ear on the head right here to prevent the tube from moving, make sure it's secure, and then it won't cause any further damage. So we'll put a couple little staples here above the ear. Others will do what's called bunny ears. This is just a little tip and trick. So your subglottic tube, I'll wrap it around my tube. So then if it's laying on the corner of the mouth, I won't get any breakdown. I don't want to cause any breakdown to my patient. And then your cuff. So there are a couple ways you can manage your cuff. So there's this, that's called a cuff later. And then this is a newer version that is single patient use, and they're super nice. So you'll put your cuff, so over on the back we have this button here that releases pressure. This is where the port where you put your cuff, your pilot balloon, and then you can pump air up here. So you'll take this little port, put your cuff on there, and then you can see how much pressure, and you want to try to get it into the green. So you can pump more air in, but if it's too much, you can release with this button. Or one thing I found is taking it off releases some pressure, so I'll just put it on and take it off until I'm to the green zone with my pressure. This one, how it works is it's a 10 ml syringe with a pressure gauge at the bottom. So you press this button to turn it on and a little screen will come on. And with that, you can put your pressure gauge and then add and subtract depending on your centimeters of water pressure provided in this little window. So play with that, get a little close. It's kind of hard to show on video. So that's securing our airway. Finally, I'm going to show endotracheal suctioning. So this port right here is to your ventilator circuit. Sometimes, since your patient can't cough, we have our airway in here. Your patient can't cough secretions up and out. You will have to suction for them. This little port right here, you can provide saline if you are going to instill clean saline into your airway. I think it's best to hold right here onto the hub of your suction and your port, so then it doesn't come disconnected. After that, I like to do what's called pinch, push, pull. So I'll take my Ballard suction, make sure you hyperoxygenate your patient. So I'll pinch my catheter and my sleeve, push it in, and then pull up the plastic bag so that it just gathers in my hand. So I pinch, push, pull, pinch, push, pull. And you will go down into your airway until your patient coughs or you reach resistance. After that, so your suction will be applied here. By pushing this down is how you initiate suction. So you'll pull back, suction, and pull, slowly pull out. So you're allowed to suction for 15 seconds. So if you get a nice little pocket, you can stop and hold there for a second to get all those secretions. I'm a believer that I would rather take the time and do fewer passes but a good thorough suction than to go down a billion times and just get little bits at a time. So just be thorough and conscientious about your patient. Make sure they are in a good situation. If you have a patient what's called vagal or Brady, where their heart rate goes down and their blood pressure drops, just make sure to provide oxygen and monitor your patient. Typically, they will come back up pretty quickly. All right, so now our patient is doing well. We are going to extubate our patient. Yay! So our patient, I will sit them up. What you're going to need for extubation is a checks, oral suction to help get any secretions, and an oxygen source. I typically will go nasal cannula unless the patient's looking like they need something else. So with that, you'll sit your patient up with extubation. You'll instruct them, okay, we're going to get that tube out. Are you excited? And then they'll nod and be like, yeah, I'm super stoked. And be like, I don't blame you. You'll need a 10 ml syringe. You will suction down your tube and the back of their throat. Make sure everything's clean. That is because every time you go to deflate this cuff, you want to make sure the back of their throat is clean because you want to prevent any secretions or bacteria from falling from on top of that cuff into their lungs to prevent a pneumonia. After that, I'll hold. I'll unsecure the tube. You can do that a couple ways. You can either bring it from the back of the head, untie, or cut your twill, and then hold your airway because you want it to be on your terms. I'll turn my ventilator completely off at this point, and I'll tell my patient, okay, this isn't going to hurt. It might just feel a little funky while I'm taking that airway out, okay? So what I need you to do is take a big deep breath in and just cough, and keep coughing till I tell you to stop coughing. So you'll take your 10 cc syringe, your unsecured airway, take the air out of that cuff, And I'll even do it a couple times just to make sure. This is to prevent any damage to those vocal cords. Okay, and then your patient will be like, oh, this feels weird. Okay, deep breath in and cough, 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 cough. Pull it out. I'll flip it onto the chucks, and then I wrap it in the chucks because no patient wants to see that. Suction their mouth really well, apply their oxygen, and then I do a post-extubation assessment, which is I have them talk to me. I listen to their upper airway with my stethoscope and to their lungs with my stethoscope. I monitor their vital signs, and then I assess for what's called stridor, which is inflammation in the upper airway that can come post-extubation. Mild is treated with a cool mist. Moderate is treated with racemic epinephrine, and severe would be reintubation of the patient. So that is emergency airway management in a nutshell. Just a quick video clip to expose you guys. We're going to get hands-on. Again, come with tons and tons of questions. This is just kind of the introduction snippet portion. So we'll see you guys in lab. Okay, bye.